Okay, good afternoon. Welcome to Grand Rounds, to our folks here, as well as the folks online. I'm Bob Wachter, Chair of the Department of Medicine at UCSF. Today's Grand Rounds is on non-insulin medications for diabetes, choosing wisely in the face of many new options. I'd say diabetes is one of those areas where, for those of us that trained a few hundred years ago, it just is staggering how many different options there are. And so we are very lucky to have Sarah Kim teach us a little bit about some of the new medications and what their appropriate uses are. Sarah is professor of medicine. Her primary appointment is in the Division of Endocrinology and Metabolism, based at Zuckerberg San Francisco General. She also is director of the UCSF Diabetes Teaching Center. She got her MD from Tufts, did a combined medicine pediatrics residency at UCLA, and stayed on there for her endocrine fellowship. But we were lucky enough to recruit her here afterwards, where she did a year of an advanced diabetes fellowship and then joined our faculty, and has really emerged as a leader in the care of and the teaching about the care of patients with diabetes, as well as obesity and other metabolic disorders. So, Sarah, thank you for being here. Look forward to hearing you talk.
Thank you for that welcome. Okay. So today I'll be talking about non-insulin medications for diabetes, choosing wisely in the face of many new options. Here are my disclosures. Tzield is not a medicine for type 2 diabetes, and I won't be talking about that today. So the treatment of type 2 diabetes is something that, if you are sitting in the audience, you might do very regularly. And this might be a nice affirmation of a practice that you are very familiar with. For other people who trained a few hundred years ago, the last 15 years has shown a rapid development in the field of type 2 diabetes agents, medications, and this can feel quite daunting and hard to sort out. So today we're going to talk about the treatment of type 2 diabetes. What is that? We have the same goal as ever, which is to achieve optimal glucose levels without excess hypoglycemia or other negative side effects, our treatment burden. The reason we do this is, of course, to prevent micro and macrovascular complications. And my talk is essentially the how. How do we accomplish this today? So I'd be remiss if I didn't mention this every time I talk about a treatment for type 2 diabetes talk, which is that type 2 diabetes is preventable and very significantly treatable with modest weight loss. We know this and is important to know because 1 in 3 US adults have prediabetes, and most of these people with prediabetes are young, meaning they have many decades to live and develop type 2 diabetes in the future, but they could keep it at bay. They can keep it at bay with key lifestyle changes that have been shown to prevent and treat type 2 diabetes. These are 5 to 10% body weight loss with a calorie-reduced diet. Any diet you want to choose works, low carb, low fat, intermittent fasting, whatever. As long as there is a weight loss, it will be effective. In addition, 150 minutes of moderately strenuous exercise per week. Moderately strenuous is exercise that through which you can talk, but you cannot sing. And it's also exercise that's going to cause some perspiration. So as you're counseling your patients with prediabetes, these are sort of the things that you want to, the features of a lifestyle habit or change or program that's going to actually lead to some significant results. The results were first proven in the Diabetes Prevention Program trial, which showed that these lifestyle changes, which resulted for this trial, a 7% body weight loss, did the best in terms of preventing the onset of type 2 diabetes, better than taking metformin, which we all know is a treatment for diabetes. But today we're going to talk about medications because sometimes lifestyle changes are not enough. And I want to go back and sort of describe the evolution of diabetes medication algorithms as they have evolved over the years. And I was able to find sort of the earliest version of like a published algorithm for pharmacotherapy for type 2 diabetes in 2009. And this algorithm, as I'll show you, was based largely off of landmark trials like the UK-PDS. The UK-PDS done in the 90s was a trial that took newly onset type 2 people with newly onset type 2 diabetes and randomize them to different A1Cs, different levels of glycemic control. The tight glycemic control arm achieved an A1C of 7, and the conventional arm achieved an A1C of about 8. So we're comparing higher glucoses versus lower glucoses. And the upshot of the trial, which is something that we all take for granted, which is lowered A1Cs, lowered microvascular complications by 25%. And we know that the lower the A1C, the better it is for microvascular complications. In addition, in 10-year follow-up from this trial, we were able to see reduction in myocardial infarction and all-cause mortality, particularly in the arm of subjects who took metformin as opposed to hypoglycemic agents. So we were able to see good effect from lowering glucoses. And because of that, the dogma at the time was that at diagnosis, everyone was to receive lifestyle advice as well as metformin. And then, because of these drugs being used in trials like UKPDS, the next medication to be used if metformin was insufficient would be a sulfonylurea. And then finally, if metformin and sulfonylurea were both insufficient to achieve A1C of 7, then we would add basal insulin. So we had this 3-drug, metformin, sulfonylurea, basal insulin. And I have to admit, when I first started practicing and teaching residents way back a while ago now, 15 years ago, this is the algorithm that I would kind of hone in for residents to remember. We would also aim for a hemoglobin A1C of less than or equal to 7%. And I want to explain a little bit of the history of that as well, and to also think about how this has evolved over time. So this is a graph taken from a different trial, but also looking at A1C and complication called the DCCT. And this is a graph of retinopathy here on the vertical axis and hemoglobin A1C. So this shows you something we all know, which is as the A1C goes up, your chance of retinopathy progression also goes up. So higher A1C, higher risk of microvascular complications such as retinopathy. And numerous studies after DCCT and after UKPDS reiterated this truth that the lower the A1C, the better for microvascular complications. But there's a consequence to quote unquote tight control, that as you try to lower the hemoglobin A1C down to what would be considered close to normal, your chance of severe hypoglycemia goes up. Right? And this is largely due to medications that we used at the time commonly, like sulfonylureas and basal insulin. And so the 7% is, in a sense, a compromise of the risks and benefits. So you're getting microvascular risk reduction, and then you're also mitigating sort of severe hypoglycemia. It was sort of the sweet spot that allowed us to achieve the complication risk reduction without undue risk of severe hypoglycemia. So 7% was our goal with the agents that we had at the time. So for anyone who's trained before 2010, that's kind of like what we learned really well. And it was kind of after 2010 that a lot of things happened and continues to happen, which has shaped the way that we see diabetes, type 2 diabetes treatment today. This is kind of a story that is an interesting one. And I took this timeline from a publication in the American College of Cardiology, and I modified it. But it's a timeline that shows some landmark events that happened in the development of non-insulin diabetes drugs. There was an event in 2007 where a meta-analysis showed that a drug at the time called rosiglitazone might be associated with increased risk of myocardial infarction. Okay, and this was after rosiglitazone had been on the market for several years. Because of this meta-analysis, the FDA became concerned and required that medications coming to market after 2008 for the treatment of type 2 diabetes also show that they are safe from a cardiovascular perspective, okay, because of this concern with rosiglitazone. Rosiglitazone was basically sort of taken off the market at that point and was put under like an FDA surveillance program. And ultimately it didn't clearly show that it caused MI, but the controversy has sort of like put it out of the market. No one really uses it anymore. But the effect of the rosiglitazone controversy was this new FDA mandate in 2008. So every drug coming out to market after 2008 for type 2 diabetes needed to show that it was cardiovascularly safe. It needed to enroll participants with high risk for cardiovascular event to show that you can give these new drugs and not cause excess cardiovascular event, okay? So this is a specific mandate for diabetes drugs in particular. What happened was that not only did drugs show they were cardiovascularly safe, they started to show that they were actually cardiovascularly helpful or superior compared to the control regimen. And so this first happened with empagliflozin in 2015, which showed reduction in 3-point MACE, heart failure, renal outcomes. In 2016, liraglutide and semaglutide showed reduction in cardiovascular event, then dapagliflozin, and then others. In the two classes, the incretin analogs and the SGLT2 inhibitors, continue to show the same effect of reducing cardiovascular event, and then also later on showing a reduction in renal events through these trials. And so this is what's caused sort of like all of the new, I won't say confusion, but sort of intricacies of how we think about type 2 diabetes medications today, because we now know that some agents that have come to market have these additional benefits, and it shapes the way they pick and choose medications for our patients. So the 2009 algorithm was this. That was easy. This is the 2025 algorithm, which is published this January in the ADA Standards of Care. It's published every January. It's really confusing. It has a lot of writing. And I try not to read it too often. But I do have a simplified version in my head. This is my brain version of the algorithm, and it's basically the same, a little bit different. But this is how I think about diabetes medications and how I will approach layering on medications for my patients. I actually have metformin still at the top. If we go back here, metformin is new, it's dethroned. It is no longer number one. It was number one for a really long time, but now it's like down here. But for a lot of reasons that I'll share, I still consider metformin my first line treatment. And then depending on other features that the patient has in particular, whether it's heart failure, CKD, high risk for ASCVD, desiring weight loss and other features, I will then think about either my second agent or concomitant agent with metformin. So I'm going to argue that metformin is still very relevant, and in this day, we still need to consider it as a standard treatment for type 2 diabetes in most patients. It's been used for a very long time in its herbal form, and it's been shown since the 1950s to be safe and inexpensive and effective at lowering glucoses. The UKPDS again showed that decrease in mortality with metformin at 10-year follow-up. And it's important to, I think, help patients to be successful taking metformin because it can have some side effects. Some prescribing pearls. I would say that most of you know this, but gradual dose increase, right? Because it has that GI upset, taking it with food as opposed to on an empty stomach. The XR version might be gentler on the stomach. All of these things will help reduce diarrhea and GI upset, which will be the reason why the patient stops the metformin. So we don't want them to stop the metformin. We also have to remember to reduce the dose in renal failure because it is 100% renally excreted. And know that lactate is a byproduct of metformin's normal mechanism of action, but lactic acidosis is pretty rare. And it's more frequent in people with renal failure. So you want to be cautious in people with lower eGFR and of older age. But it's a tried and true medication, and it's very effective in lowering glucoses, and I still use it first line. But the game-changing medication in the last 15 years have been the incretin analogs, and truly, truly game-changing. I want to explain a little bit about the sort of the mechanism of action of these medications. So these medications are mimicking normal hormones in the body called GLP-1 and GIP. These hormones, we call them incretin hormones. They're actually secreted by your intestinal cells, your enteroendocrine cells in the intestine. When the small intestine sees digested glucose, right, this will signal these cells to secrete GLP-1 and GIP. Okay, these hormones then go to the pancreas, which is why this class of medication has been used for 20 years in diabetes, to enhance glucose-mediated insulin release. Okay, so it helps the beta cell to do a better job in secreting insulin in preparation for an onslaught of sugar coming from your meal. Okay, that is why when you eat carbohydrate, your body does a better job of controlling that glucose level afterwards, as opposed to if you're given that glucose through an IV. Because if you're given it directly through the IV, you're bypassing your gut and you're not giving the pancreas that heads up that the GLP-1 and GIP allow. So this is the incretin effect that we see in insulin secretion. So we give synthetic versions of these at very high amounts. This helps with diabetes. It helps with a lot of other things too. This is just an image I pulled from the internet of all the GLP-1 benefits throughout the body. I would say that the major clinical benefit that I see are two things. Number one, the action at the pancreas. So it helps that insulin release. Number two, it's at food intake because there's a strong satiety effect of these hormones at the hypothalamus. So you're going to see a big benefit with glucose and then with appetite lowering and weight loss. And as you know, type 2 diabetes, one of the major pathophysiologic derangements is insulin resistance. And with weight loss, you improve insulin resistance and can improve diabetes. There's a lot of options of incretin agents these days. These are, I put 6 of the main different types that we can use. I'm going to get rid of a few of the ones that are not as commonly used and leave here the ones that at least I personally use more often. These are injection medications, but they're injected once a week, so it's not so burdensome. The bottom two, dulaglutide and tirzepatide, have an auto-inject mechanism. So if a person is very needle phobic, they actually don't see a needle when using this device. So you can kind of counsel patients that way. And in clinical practice and through kind of head-to-head studies, I'm putting here sort of the increasing weight loss and glucose lowering potential of the 3 commonly used brands, with dulaglutide being probably the most like sort of mild in terms of glucose lowering and weight loss potential, semaglutide in the middle, and then tirzepatide being sort of the most potent in terms of glucose lowering and weight loss. Oral semaglutide is the only oral version of an incretin agent that you can prescribe. It is a little bit fussy in the sense you do have to take it on an empty stomach for 30 minutes, empty stomach, keep it empty for 30 minutes, no other food or medication, and it has to be taken with 4 ounces of water. And it can't be more than 4 ounces, and it can't be less than 4 ounces. It has to be 120 mLs of water because of the way that that then helps the drug to be absorbed properly. It's a peptide, and it'll be easily digested. So it's in a particular vehicle that allows absorption, gastric absorption, but if it needs that 4 ounces of water, no more, no less. And you can see just like by comparing even doses, oral semaglutide, you take 14 milligrams a day. Injected semaglutide is 1 milligram a week. So you can see sort of the differential in absorption. It's very small fraction is absorbed. So you need to really take it properly in order to get the drug inside the body. But we like this medication because of its weight loss effect and because of its cardiovascular protection. So this is the cardiovascular outcomes trial for semaglutide, showing a 25% reduction in 3-point MACE outcomes in non-fatal MI, and about a 40% reduction in non-fatal stroke. Another trial in people with type 2 diabetes and CKD with a mean baseline eGFR of 49, showing a significant reduction in renal events with semaglutide. And so the renal, event improvement likely driven by weight loss and glycemic benefit. So hitting a lot of different comorbidities with one medication. Some practical prescribing tips for incretin analogs. They can be a little bit intimidating because they're injection, et cetera, and they have different doses. A few things that I've learned along the way is that I don't personally auto-titrate the medication from lowest dose to highest dose. And I've seen other people do this, which is why I got the idea. And it would seem kind of nice to kind of set it and forget it, or put it in like a, prescribe it one day so that the person can get it, increasing doses without you having to communicate back and forth about the dose. But what I've seen is that an automated increasing of the dose might lead to sort of unwanted side effects. You kind of want to monitor the patient's level of side effects at every dose before you increase the dose, because that can lead to discontinuation if the medication is causing significant nausea or constipation. You want to stay at that current dose or even reduce the dose. So I like to sort of check in before I'm actually increasing the dose of any of these medications because of side effects. I also think less is more of any medication. And some insurances don't actually allow you to increase the dose without another PA unless you've proven that there's been glycemic benefit or there've been weight loss benefits. So you may not even be able to auto-titrate up, and that leaves the patient without the medication. The other really important thing to counsel patients on with these medications is to set the expectation that this is a forever medication. And I use forever in quotes because it seems so dramatic to say that, but really, I don't see a way for people often to come off of the medication. And it's not so much because it's a good glycemic agent and why would you ever stop it? But it's because a big mechanism of the way this medication works is weight loss. And there's a particular way of the way your body regulates body weight, that if you're using the drug to maintain a lower weight, you will probably need to stay on the drug for that purpose, okay? And the reason is that your body undergoes these natural adaptations to weight loss. This isn't a weight loss talk, but just one slide, is that when you reduce your calorie intake in order to intentionally lose weight, so you're reducing energy intake on like a new food plan or diet, your energy expenditure actually goes down. And so this is something that you don't control, but that your resting metabolic rate and such decline in order to prevent or protect against further weight loss. And then your appetite goes up. And these two opposing forces make it difficult for someone to voluntarily reduce energy intake for a long period of time. And so often when we see in diet studies, for example, is that energy intake will be down in the first few months of a diet study, and then energy intake actually, you're not able to stick with the diet, so to speak, for the long term. And then the weight trajectory is such that you lose weight in the beginning and then it gradually goes back up as the diet goes on. The medication like GLP-1 or GIP, what they do very well is they suppress appetite. So if you suppress appetite, right, you don't have as much of a counterforce to keeping your energy intake down, and you're able to decrease your energy intake long term, and then your weight can stay down because you're not having to battle the appetite rise from calorie restriction. However, when you stop the medication, your appetite is what it would be at baseline, or what it would be through this natural process, which is elevated. And the return of the appetite will cause return of eating back to the amount of calories that you did before you started the medication. This is why I say that these medications are long-term. It's just difficult to maintain your weight loss without the help of the medication if that's how you achieved it in the first place. So this is just one of many different studies of different brands of these agents that show that when you discontinue the medication, the weight comes back. So this is tirzepatide, SURMOUNT-4 study. It's actually in people with obesity and not diabetes. But this is the treatment phase of the study where all the participants got tirzepatide. They were able to achieve an astounding amount of weight loss, which is 20%, sort of bariatric surgery level amount of weight loss. And then half of the participants continued on tirzepatide, half of the participants were switched to placebo. And you can see that in the ensuing 36 weeks, about 2/3 of the weight loss was regained. Okay, so this is what we see in clinical practice as well. When people don't have access to the medication or they stop the medication, their weight starts to go back to encroaching to what it was at baseline. And so being a forever medication, the reason I say that and counsel patients around that is because of data like this. In addition, there are GLP-1 receptors throughout the body which kind of talk about, which lend to some of its side effects and also their contraindications. So we like GLP-1, GIP, because they work on the pancreatic beta cell and cause insulin release to be enhanced. They bind at the hypothalamus, which increases satiety. They also have receptors in the vagal neurons, which causes the GI slowing. This is the reason for the side effects. So the side effects of these medications are nausea, vomiting, constipation. Okay. What's interesting about this particular side effect is that it does get better over time. So there seems to be sort of like a desensitization to the side effect with consistent use of the medication, but they can recur every time you increase the dose. So the person gets used to it and the side effects get better, but it takes time. There are receptors for GLP-1 on pancreatic acinar cells, so we don't use it in people with recurrent pancreatitis or pancreatic cancer. There are receptors on the sinoatrial node, which cause its side effect of tachycardia, although interestingly, it's not associated with increase in arrhythmia. And in laboratory animals, we see medullary thyroid cancer, and there are GLP-1 receptors on malignant medullary thyroid cells. And so we don't use it in a rare form of cancer called medullary thyroid cancer. So how to be successful in having patients take these long-term, because we do know that they discontinue the medications. How do we keep them on them? So some practical tips. I think if weight loss is not desired, there are some patients who do not want to lose weight, or I'm worried about the consequences of GI side effects. They're a person who will not tolerate nausea, vomiting very well. I do favor dulaglutide or daily liraglutide. Dulaglutide because it's milder, daily liraglutide because you can stop it faster. A concomitant DPP-4 inhibitor is redundant, right? At the same time as a GLP-1 agonist. These synthetic incretin analogs are made to be resistant to DPP-4. DPP-4 is your endogenous enzyme that degrades endogenous GLP-1 and GIP. So that's why those inhibitors can be somewhat helpful for diabetes, but you don't need to give both at the same time when you're giving synthetic versions. You should consider lowering the dose of sulfonylureas or insulin, especially if mealtime insulin, if glucoses are close to goal, because you might then sort of potentiate the hypoglycemia risk. And you want to do a slow titration, watching for the magnitude of glucose change, especially with people with existing retinopathy or nephropathy. So in type 2 diabetes or in any form of diabetes, if you have diabetic retinopathy and glucose levels are improved dramatically in a short period of time, there's always a risk of worsening, paradoxical worsening of retinopathy. And this can happen with insulin, this can happen with the GLP-1, this can happen with bariatric surgery. And so anyone who's had longstanding type 2 diabetes, you don't want to ever slam the glucose down very quickly. That has been seen with these class of medications because they are so effective, a worsening of retinopathy. And so these are the patients that you want to be really careful about, titrate slowly. Nephropathy can also happen, a worsening of nephropathy with these medications, probably due to pre-renal decrease in PO intake and dehydration. So counseling your patients to stay hydrated. And then if your patient misses any doses, because they do all the time due to like pharmacy shortages and prior authorizations, because of the GI side effect, you want to restart one of these agents at a lower dose than they were on before. So you want to reduce the dose due to GI side effects. Nausea, vomiting, constipation are worse when you're starting the medication or increasing the dose. And the body adjusts. So then once the body's off the medication and you restart at a high dose, they may have severe nausea, vomiting. Dulaglutide has the least amount of GI side effects, so reducing the dose after a prolonged lapse may not be needed, but you can ask your patients if they had initial side effects. Semaglutide and tirzepatide will most likely need a dose reduction if you miss more than 3 doses. Okay, so I do think that these medications are being sort of game-changing. We're able to achieve A1Cs less than 7% without weight gain, without hypoglycemia, and that is a wonderful feature of these medications. I use them quite frequently after metformin. All right. So sodium glucose cotransporter inhibitors, I think, have a little bit of a different story than GLP-1s. They're an interesting medication. As you know, SGLT2 inhibitors prevent the reabsorption of glucose at the level of the kidney. So they cause glycosuria. They also cause a diuresis as a consequence. And this is great for heart failure and great for people with cardiovascular disease. I'm not going to go into as much of the clinical data around these, but suffice to say that of the several SGLT2 inhibitors, they have really earned indications in both cardiovascular risk reduction as well as in kidney sort of risk reduction. There's more SGLT2s than I even put on this slide. I kind of get away with knowing there's a DAPA and an EMPA, and that all of those 2 ones have the most indications, either kidney indication or cardiovascular indication with type 2 diabetes, or even without type 2 diabetes. I'm not seeing those patients, but even without type 2 diabetes, there is an indication for kidney protection as well as congestive heart failure. In my mind, I'm often not using this first line after metformin unless the person has an indication for either kidney or heart failure. And the reason is because the glucose lowering capacity of these medications is typically pretty modest. And I usually have a lot of A1C lowering to accomplish. You may not in your patient, and so an SGLT2 might be appropriate. But the glucose lowering potential is modest, especially compared to a GLP-1. By design, they do reduce eGFR, and it's contraindicated in a low eGFR. And this is like a really pesky side effect, euglycemic DKA. We know that it's real. People in the hospital know that. You see that all the time. And it's really hard to counsel people around that. It's like, what do you say? Like, one day you might feel bad, and it could be this drug, and it could be DKA, and the only thing to do is go to the ER and get IV insulin. It's like, it's almost so vague and nonsensical that it's not worth kind of counseling the patient about. But you don't want to use it in people at high risk. So you're not using it in type 1 diabetes where they don't make endogenous insulin. You're not using in people with recurrent DKA who show that they can get into DKA easily. You're trying to avoid it in people with other high-risk features for DKA, like maybe they have a pancreatogenic type of diabetes where they're not making insulin themselves as much. They're needing basal and bolus insulin, which is sort of a clinical sign that they are not making their own insulin. And they have a type of diabetes with a lower BMI that is more insulinopenic rather than insulin resistant. So those features might be sort of signs that an SGLT2 inhibitor could be risky. And you always want to counsel the patient to hold it if they're NPO. And this is because when you're NPO, your own endogenous insulin goes down. There's a higher risk of euglycemic DKA when you're NPO and taking these agents. And you need to stop them a few days in advance of NPO because it does have a very long half-life. I think people know more about the UTI and genitourinary mycotic infections. So tips around that would be to keep genitals dry, especially people who don't usually use toilet paper when they urinate. They may need to, and to caution use if you have a history of UTI or severe UTI or pyelonephritis. and or like you're immunocompromised, for example. You want to just use a lot of caution around that. So if you go back to my simplified version of the algorithm, you'll notice that under metformin, depending on which other comorbidities you may have, I'm choosing either a GLP-1 usually, and or an SGLT2 inhibitor as often my second drug or concomitant drug, or maybe both, depending on the specific comorbidity. I haven't talked a lot about the other considerations and other diabetes medications, but I certainly use some of them I'm going to talk about too in particular. So the medication I use more often than you think based on my slides is sulfonylureas. I use sulfonylureas a lot still. They're cheap, they're fast, they're effective, and they're an alternate to insulin so long as your beta cell function is adequate. I like them because they're old and they have a long safety record. We know what they can do. We know what they can't do. Like insulin, really their main side effect or only side effect is hypoglycemia. And this is if you give too much for a given context. So it's really reassuring in that way. They are renally cleared, so you have to be cautious about dosing in renal failure. And 99% of the time I use Glivazide because it's a shorter acting sulfonylurea. I use 5 milligrams because there is some data that 10 milligrams per day is kind of your therapeutic max. And I dose it once or twice before meals. I use this often in context of really high blood sugars, which I'll get in clinic for people who are newly diagnosed with type 2 diabetes. They're referred from the ER, their A1C is 14, they lost some weight, and their point of care glucose is 300. Sulfonylureas can be pretty effective in lowering glucoses. They're also really effective as temporary use if someone's on steroids and they briefly have hyperglycemia after meals. Sulfonylureas can nicely bring down blood sugars in this context. So it's kind of like poor man's insulin, but I like it a lot because it brings the glucoses down to a manageable level. And then in follow-up, maybe a few months down the road, I might swap out that sulfonylurea for like a GLP-1. But for getting someone from really high glucoses that are losing weight, et cetera, down to normal glucoses within a few months, sulfonylureas are really nice for that. And then the medication I use very less often than you think based on my slides is pioglitazone. So pioglitazone is a medication that's really interesting. It's a thiazolidinedione. It's really a pure insulin sensitizer. So it's a nice sort of mechanism of action because insulin resistance is so a key part of type 2 diabetes. There's shown some benefit in pioglitazone in MASLD. So if people have metabolic associated steatohepatitis, pioglitazone may be beneficial. And there's no hypoglycemia. So that's really nice about pioglitazone. But there are some cons to pioglitazone, and this is probably why I avoid it or I tend not to prescribe as often. So there's weight gain, which is fat gain plus fluid retention. We know that we need to avoid it in fluid overload states like CHF. You can't use it in acute liver disease. And there's this interesting increase in bone fracture risk and maybe some data that in men who've used it for a long time at higher doses, they could get some increased risk of bladder cancer. So then I'm kind of like talking myself out of starting the medication a lot because of these side effects. Not to say that nationally or globally people don't use pioglitazone. I don't want to sort of give that impression. There are renowned diabetologists who put everyone on pioglitazone plus a GLP-1 because of the insulin sensitizing effects of pioglitazone. Some other people are fans. I don't use it as often because of the side effects, but I wanted to mention this could be something in the armamentarium, especially if fatty liver disease is a big comorbidity. Okay, so just to conclude this, I will say that 20 years of diabetes 20 years, 15 years of diabetes treatment can be boiled down to four steps. I kind of want to simplify things into 4 steps because type 2 diabetes treatment can look like a big, scary blank slate, but it's actually not that bad. So I'll take you through how I think of a patient. Step number one, when I'm meeting someone, is I confirm in my mind the diagnosis of type 2 diabetes. I want to make sure that's what I'm treating. Things that confirm this in my mind, they are overweight or obese, especially centrally. They have a presence of hypertension, a very common comorbidity. They have dyslipidemia, low HDL, high triglycerides, and they have a family history of probable type 2 diabetes. If all of those things are there, I feel pretty confident in my diagnosis. Other soft criteria is they tend to be older with type 2 diabetes, not younger. They are in a self-identified racial group with a high prevalence of type 2 diabetes, like Hispanic, Pacific Islander, South Asian, and they have a lack of autoimmune conditions in self or family. So if there's a lot of autoimmunity in self or family, I kind of start thinking about autoimmune diabetes. But if I'm pretty convinced it's type 2, I go to step 2. And I ask myself, how much glucose lowering is desired, okay? If you need a lot of glucose lowering, if you want to lower A1C greater than 2 percentage points, so you're at 9 and you want to bring it down to 7, you have to start with something potent. Usually 1 or 2 medications started simultaneously or in succession. So we're talking about metformin, we're talking about a GLP-1 or GLP-1 GIP, a sulfonylurea, or maybe insulin, okay? These are your big guns in terms of lowering glucoses effectively. You don't want to, again, lower glucoses too quickly because I said before, you'll have a paradoxical increase in retinopathy or nephropathy. If you don't have a lot of A1C lowering, those aren't my patients, but they could be your patients in clinic. You want to lower A1C only 1 to 1.5 percentage points. You can do metformin, DPP-4 inhibitor, which I didn't really talk about too much, SGLT2 inhibitors, maybe especially if they have nephropathy or CHF, or other medications that are fine. They're just not as potent at lowering glucoses. And then in the new era, we think about special considerations such as renal or CHF. We want to use SGLT2 inhibitors at the start. Steatic hepatitis, hepatic steatosis, we might want to consider pioglitazone, although there's a lot of good data that incretin agents, GLP-1, GLP-1 GIP can improve steatosis as well because of the weight loss. And if you suspect very low insulin production, someone with a history of DKA, pancreatogenic diabetes, autoimmune diabetes, you're looking at insulin as a consideration. And then very lastly, but not least, is that you can't medicate, even with the most expensive drugs, you cannot medicate a diabetes unfriendly diet. And we don't ever talk about diet because you don't learn about it in medical school, but it's 50% of the equation. When you do inpatient diabetes, it's 50% of glucose management is managing the food, not the insulin. So the top 3 to address: sugary beverages and foods, and then ultra-processed snack foods and refined grains. It's if you don't say this ever, you'll never be successful, no matter how many expensive, numerous diabetes medications you prescribe. The diet is half of the story. So always just saving a couple minutes to talk about that. So we'll take us home with some of these take-home points. Diabetes management has evolved to target lower A1Cs and reduce complications even better than before. Metformin, I think, is still relevant and should be considered first-line therapy. Most people with diabetes would benefit from some weight loss, so lifestyle changes and incretin analogs should be considered as well. Incretin analogs and SGLT2 inhibitors are especially great for people with cardiac and renal disease. And then just a shout out to good old-fashioned sulfonylureas, which are inexpensive and effective, especially when glucoses are very high. We'll just end there, take questions.
Thank you, Sarah. That was great and very practical. Let me start with a couple. Do you worry when your patients get admitted and they're on metformin and glipizide? The house staff will say, "What's going on here?" Like, why? Like when I think about patients of mine who are on digoxin, they assume that I haven't read a journal article in 30 years.
Oh, I don't worry about my reputation anymore in terms of that. You know, metformin and sulfonylureas I use all the time, and I'm not just saying it's because I work in the county a lot, but they are very effective medications. Sulfonylureas, you know, you can often swap them out for a non-hypoglycemic agent these days. So, I'm trying to do that in practice, but they're a great foundational, regimen for people with type 2 diabetes. So I think it's fine. We often use it on discharge as well, because again, it's a fast sort of effective medication regimen that gets people off insulin, as you can discharge them on those medications as well often.
Do you ever, what are the situations where you favor early insulin as opposed to, you've given us 3 or 4 drugs and you can
Yeah.
imagine escalating to 3 or 4 drugs where sometimes the right choice might be early insulin?
Yeah, so that's a good question. So, type 2 diabetes is a marriage of 2 processes. Number 1 is insulin resistance. Number 2 is beta cell failure, right? And type 2 diabetes, so the individual with type 2 diabetes will have a mix of those 2 things, but the specific person in front of you may have more insulinopenia or beta cell failure and less so the insulin resistance part. And another person might have just a ton of insulin resistance, but their beta cell function is quite intact. And so it's the people on that end of the insulinopenic, the beta cell failure predominant type of type 2 diabetes that's going to benefit from insulin early. How do you know that clinically? It's harder to tell. It's something we teach the fellows, lower BMI, higher glucoses, strong family history of needing insulin, DKA. Those things can be features of insulin requirement, but it's often sort of trial and error and failure of non-insulin medications that gets you there pretty quickly. Yeah.
And I noticed maybe a parallel question that when you talked about step number 1 is ensure that it's type 2.
Yeah.
There was nothing about any kind of blood tests.
Oh, yeah.
Antibodies, insulin levels, any of that stuff. Where does that fit in at all or not?
Yeah, no, that's interesting. I think it's like recently recommended to test so many, everyone with antibodies. I will say that this is what I do. I test antibodies when I'm not 100% sure it's type 2 diabetes. And I have a pretty low threshold for testing. So if the person has severe diabetes, they're young, they've had DKA, they need insulin, they have a lower BMI, they have a negative family history, they have lipids that look great, they don't have hypertension, they don't have metabolic syndrome. Those are tip-offs for me that a GAD65 or an islet antibody would be worth the time to get. You can get those 2, you don't have to get all 5. And then if those 2 are negative, you still have a really strong suspicion based on the clinical presentation, then you can get the rest. But that would be sort of a cost-conscious way of getting antibodies.
Okay. My last question, then we'll open it up. The oral GLPs seem pretty unwieldy and 4.00 ounces of water. Are there better ones coming?
Yeah. So the semaglutide for weight loss is I think coming out. So bigger doses of oral semaglutide for weight loss purposes. I think it's like 50 milligrams. They're bigger doses, and I'm sure other formulations that are coming out. It's not that they're kind of finicky. If you get them well absorbed, they can perform as well as injectable. It's just that absorption part that could be tricky.
Let me open it up to folks here, and then we'll go online. Questions, comments? And say who you are.
Mark Anderson, director of the Diabetes Center. So Sarah, great job. I thought maybe a comment about CGM use in type 2 diabetes might be appropriate.
Yeah.
For the clinicians to see where we come down on that.
Yeah, so continuous glucose monitors have been shown to improve A1C in type 2 diabetes about 0.5 percentage point. And this is probably due to the feedback that people get from their behaviors and their medications that keep them, adherent to those. They are not easily covered unless you're on insulin. So even if you think your patient might benefit from it, it's going to be hard to get insurance to cover it. There are over-the-counter CGMs these days. I don't know if that's where you want to steer your patients towards, but they're getting easier and easier to get, so maybe the price point will go down. I think it's nice to have CGM data for everybody, but most important people on hypoglycemic agents like insulin.
Great. Others in here? All right, let's see what's online.
Great. That was an awesome talk, Sarah, Dr. Kim. So a couple really great questions online. One is from Dr. Alba Wynn about kind of how you approach a new diagnosis of type 2 diabetes on the inpatient side. Like, what do you discharge people on? How do you kind of triage intensity of therapy with pill burden and feeling overwhelmed with maybe a new insulin start? It's a big question.
It is a big question. I think that discharging someone on insulin is often the easiest thing to do cognitively, but one thing that I try to think about when discharging someone on insulin is, will they fly on non-insulin medications? And there's some ways that I think about it. So one way is to think about how how much insulin they need to maintain euglycemia. And I think about it as a per kilo calculation. So in my own brain, this is not published anywhere. If it's like about less than 0.5 units per kilo, I kind of think, well, maybe we can kind of, patch together oral agents and non-insulin medications, and the person will fly because they have enough of their own beta cell function. But if we're needing more than that, then likely they're not going to be euglycemic or near euglycemic upon discharge. So the best thing is often to keep them on the insulin, even though it can be a treatment burden, especially since the person with hyperglycemia in the hospital is often battling something they need good glucose control for, like an infection, right? So you don't want to just discharge someone and say, oh, it's all right if your blood sugar is 300 because they just had a toe, ulcer or whatever. You do want to maintain really good glucoses. So that might mean a discharge on insulin with a really close follow-up with their primary care or diabetes clinic.
Just a quick follow-up. Just a quick follow-up. Do you ever start people on 2 orals at the same time, and you're always doing this sequentially?
No, the question about 2 orals, I often do 2 orals at the same time, depending on how high the glucose is. So for above 9, we're often using 2 at the same time. Yeah.
There was one more question from the chat about whether GLP-1 agents are okay in patients who've had bariatric surgery.
Okay, good question. So yes, they're perfectly safe in people with bariatric surgery. Some people might think, well, what's the point? Because you've had the surgery and your incretins are changed surgically and you have, enhanced GLP-1, but there's been pretty good, at least clinical experience with GLP-1s after weight regain from after bariatric surgery, that they can work to then bring the weight back down, or they work in diabetes. So if it's persistent, so you can use it after bariatric surgery.
Your first. Sure.
Hey, I'm Ray. I'm a medical student on the medicine service. I'm just curious, in terms of overall follow-up interval, what do you kind of benchmark on to determine like how long you want for follow-up? Is it based on A1C, how many agents you're starting, or kind of other risk factors at play?
So good question. In terms of follow-up, I would say that if you're having someone who's pretty hyperglycemic and you're not sure that the regimen that you're putting them on is going to be sufficient, then I would see them within 1 month. If you're pretty sure you got something that's going to work, then of course a standard 2 to 3 month follow-up is fine. Yeah, it kind of depends on your confidence level and how poorly controlled the area.
Hi, thanks so much for a great talk. Wondering what your recommendations are for considering metformin in prediabetes.
Mm-hmm. Yeah, so metformin can be used in prediabetes. I showed you the diabetes prevention program, which showed that metformin also was more effective than placebo in preventing the onset of diabetes. It was an interesting study because when they tested for the presence of diabetes in the diabetes prevention program, they used like A1C and OGTT, and the people were not necessarily off their metformin. So I don't know if you're treating diabetes versus actually preventing diabetes with metformin, but I think it depends on your glucose level. Hemoglobin A1C in the low 6s, there's a fairly low risk of future complications. So, weighing the risks and benefits of like being on metformin long-term, it's a pretty safe drug. The only sort of significant side effect besides diarrhea would be like a B12 deficiency. And you can see that in about 5% of people who take it long-term. So you can use it as a way to prevent diabetes. I don't see those patients very often. I would probably really hone in lifestyle changes and try to get them engaged in that.
What explains the fact that you put metformin #1 on your list of go-to drugs and the professional guidelines?
Being different?
Your practice setting, or is sometimes the professional guidelines are tainted by corporate interest? There are other things that are going on. So how do you?
Right, yeah. So I think 2 things. #1, metformin never had to undergo a cardiovascular safety trial because it was out in the market before 2008, right? So it never had that requirement. But I think if it did, this is my guess, is that it might have shown benefit. It's weight neutral. And there's a lot of sort of observational data that metformin is associated with better cardiovascular outcomes. So it might have, right? The other thing is that it's very inexpensive, and I would love to give everyone a GLP-1, but we're gonna break the bank until the price point comes down. And liraglutide is now generic as of December 2024, so it's happening. But we have to think about the whole system. And, I don't know, several thousand, $10,000 a year for GLP-1s. It's not cheap right now.
Right.
Yeah.
Anything else on that? Yeah, go ahead.
We have a lot of questions in the chat. One question from Dr. Lyons, as a PCP, I'm wondering what the most common missteps you might see in the primary care setting.
Oh, you guys are all perfect. I never see a misstep. I think, okay, so when I do like clinical trial stuff and we're enrolling people from across the country, what I see a lot is over insulinization of people with type 2 diabetes and people on like 200 units of insulin a day, because you want to get the A1C down and and insulin can be titrated ad infinitum, right? But that's going to lead to weight gain, hypoglycemia risk, and it's really hard to actually achieve sub-7 A1Cs without those side effects with insulin. So I think everyone got the message from 2009 that insulin's really important. It is, but now we have to kind of pivot a little bit and really consider GLP-1s. I think more first line after metformin for type 2 diabetes because of that weight loss. I mean, we've never really had a great weight loss medication. And that's been sort of like the thing we've never been able to accomplish, but we can accomplish it now. So thinking about GLP-1s earlier, rather than sort of grabbing the insulin after, the first or second agent fails.
Great. Another question, maybe less diabetes related, but centered on metformin. Talk of metformin for healthy aging.
Oh, gosh.
So wondering about your thoughts on that.
I mean, there's so many things that have prolonged the lives of mice. And I don't know first, we don't have any human studies that show that metformin prolongs life. Maybe we could have someone come in and talk about the AMP kinase and how that is an mTOR and all of that. But I think suffice to say is we don't have any human data on that.
Sure. What are your thoughts on acarbose?
No, acarbose can work. Acarbose is a not very powerful medication, but it is a alpha glucosidase inhibitor, right? So it prevents digestion of carbohydrates in the GI tract. It doesn't do it 100% by any means, but in China they use it a lot, and I think it's because people eat a lot of rice, and so it helps a lot. But it can cause some flatulence, but it's pretty harmless. You can take it. It has to be taken through every time you eat a meal. So it's a little bit of a pill burden, but again, you can use it if it works for your patients.
Time for one more. Any more on that?
Yeah.
Maybe my last is any idea of the mechanism of the retinopathy? I thought that was interesting and have no idea what's going on there.
Right. So the retinopathy in the GLP-1s, I think, is the rapid glucose reduction, but there is this other entity, NAION, which is maybe people haven't heard of it, but people in the diabetes circle have. So it's a different type of cause of blindness that is sort of emerging as a concern with GLP-1s. I think the data with that is a little too early to make any conclusions, and I certainly don't talk about it overtly with patients unless there's a very sort of weak argument to even start the GLP-1 in the first place. This type of blindness or vision impairment is due to ischemia of the optic nerve. So it has nothing to do with retinopathy per se. It might be a blood pressure issue, because I think other causes of this condition might be fluctuations in blood pressure. And certainly if you lose a lot of weight, you lose blood pressure, but it's really unclear what the true mechanism is and if it's really an association. So, but that might come up in conversation.
Sarah, you've taken an incredibly complex topic and really distilled it down for us. Incredibly helpful. Thank you so much. Appreciate it.